Hi, how are you? Who am I
We are
talking to?
fine. I'm Dr. Belma Tursen from Turkey.
Fantastic. Hoş geldiniz.
Uh, you too?
Fantastic. That's the only bit of Turkish I know. Okay.
Yeah,
Now listen, I
great.
know you're up against time, so we're going to
Yeah.
basically get to the point. We
Yes,
have a
please.
very, very nice model here. This is Mona. She's 32 years of age. She's pretty much untouched. I could spend 2 hours talking about her wonderful face, and we can
I
go
know
through.
her face.
You know her face. She's
Yeah.
very recognizable. You've probably seen her smiling away at the booth. But finally, I've managed to get her to do her treatment because she's been asking me for many years. Now, let's cut to the chase. Facial assessment is very, very important. Before you even start, if your facial assessment's incorrect, everything else is going to be incorrect. So we have to have proper strategies. So I'm going to look at her face. So in order to do that, I'm going to get her to look at the camera so that right, we'll go into that camera there. Not too close. Come back a little bit. Okay, fantastic. That's enough. Thank you. Just straighten her up. Keep your head dead still there. Now, we want to have a look very carefully at the upper face, mid face, and lower facial regions. Now, you'll see, even though she's only 32 years of age, she does have a degree of brow ptosis, which is now giving her the very, very early signs of dermatochalasis and slight hooding. Now, this, quite frankly, can be very easily rectified using toxins. So I don't think we need to necessarily look at placement of filler. However, as we all know, by volumizing the tail of the brow and into the temporal region, the lower part, the inferior part, we can achieve a degree of lifting. But for the interest of this demonstration, I'm going to concentrate on her mid-face and her lower face. And you'll see she does have the early start of the dreaded tear trough sulcus, the nasojugal sulcus. And, of course, you'll see, if you look in the camera, there, flattening of her central maxilla here, just in this region here, which is contributory, actually, to the fact that she has deepening of her tear troughs. It's all part and parcel of the same problem. And in her case, because of her age, it's not due to bone resorption. So we can't put it down to maxilla resorbing and retreating. This is more to do with movement shift, quantitatively and qualitatively, of her fat pads, both the deep and the superficial. But in this case, possibly the superficial fat pads. But quite frankly, volume is required here, and that's what we're going to focus on. All right, so we're going to reboost this area, which is going to give her a more feminized appearance. It's also going to help structure her face, and we'll look at the lateral section as well, because in fact, she has a long, narrow, rectangular face, so we want to try and enhance a very nice heart-shaped face. We can achieve that by just tweaking the bizygomatic distance, okay? Because effectively, by lateralizing our placement of volume on both sides, we will achieve a very nice, more feminine appearance. When we look at the nose, you'll probably see, if we look at the profile view, so if you just sit, the profile view, making sure that we have a good, I'll just have a look, and we've gone a bit too far, chin up slightly, that's perfect. And we can see she hasn't actually had any treatment of her nose, she says. You're probably of the same opinion as I am, that the root of her nose, the frontonasal sulcus, is a little shallow. And that gives this appearance of a very long nose, okay? Because the root of the nose actually starts just pretty much at the tail of the brow. Now, we never really want to have the sulcus there. So we can play tricks with this, because in fact, we can do a number of things. You'll see this a little bit of a volume loss just in the forehead area, so we could re-volumize that area. That's one strategy. Or in fact, what I'm going to do today, later when I finish, is actually raise the tip of the nose, so decrease the distance of her, the actual dorsum. And that will give the appearance of a shorter nose. So it's a very nice little thing that we can do for her. Her lips are lovely. I like her lips. I mean, she's got a very nice balance from the facial view, but profile view definitely could do with some improvement. Particularly if we look now, we will look at the lower facial region. We can see she has a retrognathic mandible. And it's quite an interesting situation, because not only is her symphysis, that comprises of course, the gnathion, menton, and pogonion, is actually reset and recessed, but also the labiomental sulcus. here's a very interesting feature that I picked up on earlier on, and I'm sure you've all seen it. It's what we call the elephant in the room, and that is if we look at the camera. Which camera do you want me to look at? That one there?
Yeah, this is.
You can see there is a skeletal discrepancy here. There is, if you haven't picked up on it, you'll notice that her chin, her symphysis, is actually off to her left. And this is because, smile. Okay, open your mouth slightly and smile. Teeth go. You'll notice there is an occlusal cant. This is a skeletal discrepancy between the right and the left, which is affected because she has a shortened ramus on this side. This is manifesting itself in many, many ways. It's, of course, giving you the aesthetic negative appearance, but it also is comprised of her TMD. Open wide, close, you'll see the translation of her joints. So what we have here is a situation where the discrepancy with the heights of the ramuses are affecting condylar tracking. We also will find that we are predisposed to jowling on this side when we're not on this side. It's really interesting to see. And that's purely because of the skeletal scaffolding that exists. So without much further ado, what I'm going to do is actually talk through the treatment and actually get to work. So we're going to start by I'll treat one side of the face in the interest of time, and then off camera, we'll treat the other side. So we'll treat the side that's closest to myself. So what I'm going to do, I'm just going to make some points of reference for myself so that I have a keen eye as to what we're going to try and do here. So with the OC line here, from the orbital margin down to the oral commissurial crease, we can actually gauge a very nice pattern and look straight ahead at the camera. That's lovely. Demarcate the medial extent of the tear trough sulcus and, of course, the superior extent. Look up. Look right up to the ceiling. That's lovely. And we'll mark off the infraorbital margin. This is a very, very handy thing to do. It's very simple to do, but it also, whilst you're treating, it gives you that reference point so that you know that you're not going to violate and inadvertently augment the eyelid, which is, of course, a big no-no. Okay, that's fine. I'll just want to have a look at your OC distance, and we'll notice that we are actually 3.5 centimeters. So we'll just make a reference point here. So existing zygomatic distance from the OC line is actually 3.5 centimeters. And we want to improve on that, so we're going to go further back from that point when we augment. Okay, that's great. The other
So
thing
we have 10 minutes late.
Okay, no problem.
Time left.
Okay, no problem. We'll get to work.
No problem.
Right.
Okay.
Put your head back for me. Let's get to work. Okay, can I have? We're going to start with classic. This is Pluryal classic with a cannula. And I'll just have the needle, which is just next to you there. It's just here. I think my earpiece has just come out there. Let me just put that back in. This is the needle. She's been sterilized, so we don't disinfected, so we don't need to worry about that. And we're just going to penetrate through the dermis. If you just come closer there, that's lovely. We'll aspirate, and we'll get to work. This one, take it off. Thank you. If you just support it. Can you just support this for me? Not you. Here, give me your hand. That's it. Just let it rest. Don't touch it. Just let it rest. Let it fall. Because otherwise you'll influence the placement. Okay, pull it out. Take it out. Pull it out. Thank you. Good. We're going to go down to maxilla. And then we're going to dissect through the deep plane so that we can then penetrate through the orbital retaining ligament. Okay.
This is better view.
Can you see it?
Yeah.
If you can't see it, tell me, and I'll move. Okay. Are we good? Good.
Yes.
Lovely. Once we're in the right plane, it becomes a very simple case of augmenting very gently and very, very gentle pressure. Taking into account, of course, the anatomy of this region. This is tiger country, remember. So we need to be very, very mindful of the fact that we're traversing the infraorbital foramen, out of which exits the infraorbital artery and nerve and vein. So we have to be very careful. You'll get a degree of bleeding, of course, but this won't be arterial or venal bleeding. This will just be capillary. That's good. And I'm working lateral now, and you can see here, And this product,
We can't see now.
okay, tell me if you can't see it and I'll move happily. And then, placement of product just into the central cheek. And I'll have a gauze then, please. Okay. I'll have a gauze, tissue, what do you call it? I've got a wonderful assistant here. She's actually a doctor herself. Okay, could you get me now the volume with the cannula? So you just need to put the volume on, that's it. No, that's fine. That one there, volume. Okay, get me volume then, please. With the cannula. You'll see already the augmentation. We're just waiting for the product. Always make sure that the product is on securely. And then what we're going to do is, remember I made a reference point for myself. Laterally, I'm going to now traverse through on the bone, making sure I'm in the, effectively the deep fat compartment.
We can't see. Maybe closer view.
Okay. Can you see?
Okay, yeah,
Okay, that's wonderful.
wonderful.
Good. Making sure we're right in the depth of the, it's actually the pre-zygomatic plane. So we're just above the periosteum here. And we're using volume here because we need volume. Okay. That's lovely. I can have a gauze. Fantastic. And you'll see how effectively we've now recreated the tear trough and the zygoma all in one. And we'll of course mold this product to make sure there's no step deformities. We can do this later, but you'll get an idea as to what's been achieved here by actually widening this. And so when we get up, we'll see. Okay, what we'll do now, we'll move on to classic, please. If you get me classic, and if you get me the needle here, thank you. We're going to work on labial mental sulcus, just here. Very important you do this with a cannula, in fact. Classic, thank you. And again, just support, let go, pull it out, thank you. The reason you don't really want to use needles here, it's very easy to perforate the oral mucosa. So it's always a good point to just check intraorally to see that you're actually in the right plane. Believe me, with a needle, it's very, very easy to actually violate this and perforate intraorally. I've seen it before many, many times. So what I'm doing here is just trying to shallow out this labiomental sulcus in readiness for my chin augmentation. And if you could get me volume, please, with a needle. So we're going to place this.
How many milliliters?
One.
Do we need?
You need at least 0.5 to 1 in this area, depending on the depth. This area will soak it up, because this is support. So we're putting a slug of product right in the depth of this sulcus. Can I just have the gauze? Thank you. Now what we're going to do is going to have pencil, please.
Can we compare
Well, wait
this half with the
1
other
second
half?
until I've done
Okay,
the chin,
okay.
because I'm conscious that you're obviously up against time. So we just want to now mark off the center line. Needle, please. Okay. With volume. Needle volume. Oh, lovely. Fantastic. Okay, so what we're going to do here is, you probably noticed, if you sit the patient up, her lower facial height is actually quite long, so it gives her a very masculine appearance. So we're going to lift the chin, and we're actually going to cause protrusion of her chin in the right vectoral direction. And that's very, very important when you're doing chin augmentation. Otherwise, you could end up lengthening when you don't want to lengthen. So the point here is going to be gnathion. So what we're going to do is augment the gnathion very, very carefully, down to bone. Very good patient. Just lift your chin slightly. Can you see this all right, guys? If you can't,
we
tell
can't
me.
see, unfortunately.
Maybe the camera can move, or you tell me.
Maybe the camera. Yeah, this is better.
Unfortunately, I can't
Thank you.
see what you're looking at because I don't have a monitor, I'm afraid.
Yeah, you're right.
And
Now
watch what
it's
I'm doing here.
okay.
Now, this is important. You remember the midline shift? So what we're doing is correcting that by actually prioritizing the right compartment. Gauze, please. Thank you. Hold this for me. Thank you. And can I have one more? A volume with a needle. And you'll find when I sit the patient up that the distance between her columella and the lower lip to the menton ratio will have improved it to more feminine proportions. Okay, so what we're going to do now is just place a little bit more product. This product often you can place quite happily in a retrognathic chin. It often will take 2 mils. I wouldn't put more than 2 mils in any one session though. Too much expansion too soon. And it can be quite uncomfortable for the patient. So it's better to actually do the treatment, see them for a review appointment, and then look at placement, further placement if necessary. And you'll see now I'm
You
prioritizing.
can't see now. Yeah,
Is that better?
that's better. And a closer view maybe.
Okay. And I'm very
So
carefully.
we have 1 minute left, sorry.
No problem. I do want to do her lips, so I'll probably do her lips off camera then. And then I do want to do the tip of the nose. Can you get me now classic with a needle, please? That's her chin done, and then we'll just quickly.
Let's make comparison.
Do you want to do that now before I do the nose?
I don't have time, I think.
Okay,
because
so we'll
next-
have to do that. I'll just make sure that everything is good, and we can do a comparison then. Okay, take these off. Right, do you want to sit up for me? Right. So, which camera do you want to look at? That one?
Yeah, this one.
Right. So I'm going to move the patient now, and you can see already with this very unflattering light, when you look at the OG curve of this side, all right, and you have a look at that beautiful lateralization of her, the volume, compared to this side, which is of course a lot flatter, and the tear trough has actually improved on that side, and of course we can place more treatment if necessary. Let's have a look at the profile view. That's important because when we look at the profile view, which camera are we on? That one. Okay, no, you go. And you'll see we still need to, of course, do her lip augmentation. That's important. Now, what we'll do here is we will actually improve by prioritizing the lower lip, and we'll maybe tweak that chin slightly. And of course, that nasal tip will actually then improve the overall appearance of the face very nicely. Okay.
Yeah, thank you.
Beautiful.
Yeah, thank you
I'll
very
finish
much
this
for
off,
this.
guys. I'll finish this off camera, and maybe if we get a chance, we can come back and you can see the final result. Thank you very much,
Thank
guys.
you very much
Take care.
for this nice demonstration.
Thank you.